Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to you all on behalf of Otorhinolaryngology Hair and Neck Surgery Department. It's a pleasure for me to welcome you all for this breakfast at UMHealth session. Today's session, we are glad to have one of my colleagues to deliver a talk on voice rehabilitation post-total laryngectomy. Beforehand, let me give a brief introduction about him as an honorable speaker. At just 34 years old, he has already made a great stride in the medical field. He obtained his MBBS and Master in Otorhinolaryngology Hair and Neck Surgery from the prestigious University of Malaya and currently practicing in UMMC. We are happy to have him share his insight and expertise with us. Please give a warm welcome to Dr. Redzwan Shah to deliver his speech.
Assalamualaikum. Good morning to everyone. Thank you very much, Dr. Aiman, for the kind introduction. So let us begin. So the topic of my talk today would be voice rehabilitation post total laryngectomy. So I'm going to break down my talk into something short and simple. We'll start off with a brief introduction of what is total laryngectomy, aspects of rehabilitation, mainly voice rehabilitation, and the types of voice rehabilitation that we have, and also the pros and cons of each of it. So, total laryngectomy is a surgical procedure whereby the larynx is totally removed and the airways is interrupted. So, as a result of this, as you can see from our diagram, when we remove a larynx from a human being, they not just lose the conduit between the nasal cavity and the lower airways, but they also lose the ability to speak because there will be an interruption of air from the moving to the vocal cords, which is the basis of us speaking. So because the air in a normal person, well, it enters to the nasal cavity, and during exhalation from the lungs, it goes to the vocal cords with the movement of vocal cords, together coupled with the articulators in your tongue, your lips, mouth, and also the resonators of your sinuses produces the speech that we normally hear. So when we subject the patient to a total laryngectomy, patient would results in a loss of ability to phonate because there will be a loss in their normal anatomical structures of the vocal cords. So imagine someone who's been speaking or even singing all through their life, and suddenly they had to go through such a huge major surgery and they are unable to speak. So mainly the problems faced by laryngectomy patients are altered communication and social interaction, and this results in their inability to sort of express themselves verbally, which can cause them to have some psychological distress and also emotional challenges. This can also result in spouse and intimate relationship difficulties. And we are focusing, there are many aspects in rehabilitation in a post-laryngectomy patients. There are voice, speech, pulmonary, swallowing, olfaction, and also psychology. Looking at patient as a whole, psychological rehabilitation is something that we should not miss. So we'll be shifting our focus to be in the voice rehabilitation. So I would like to broadly categorize voice rehabilitation. So there are into surgical and also non-surgical rehabilitation. Looking at non-surgical rehabilitation, the few common methods, common ways of rehab is esophageal speech, the use of electrolarynx and non-verbal cues such as sign languages, writing, texting, etc. Surgical rehabilitation includes tracheoesophageal prosthesis. So esophageal speech. So in a normal, as I've mentioned earlier, normal conversation, how the air flows from the nasal cavity to the lungs, and from the lungs during exhalation, it goes to the vocal cords. But when we do a total laryngectomy, we don't really have any of those normal structures anymore. So patients who are undergoing esophageal speech, this is basically how it looks like. So the air is actually swallowed into the cervical esophagus, and as it is expelled out, it causes the vibration of the pharyngoesophageal segments, which are made up of musculatures and mucosa of the lower cervical area, including the cricopharyngeus muscle. So these vibrations, together with the articulations of the tongue, the ribs produces the speech that we are familiar with. So there are pros and cons with esophageal speech. So the good thing about esophageal speech is that there is no added cost. It's free basically. There's no additional surgery required, no involvement of any prosthesis and prosthetic related complications. It is also hands-free. But the downside of it is that patients can only speak in short bursts of speech. The voice quality generated is rather poor, and it's also quite difficult to control the loudness and pitch. And it is a difficult task to learn. So training is actually accompanied with support from other patients who are successful in learning the esophageal speech. The success rate based on certain studies show a range from about 14 to 76%. Well, it of course varies from a case-to-case basis and the support that the patient has. So let's move on to electrolarynx. So this is how a typical electrolarynx look like. It's a small portable device with a button at the top. So it's a battery-operated vibrating device. So there are two types of electrolarynx: the external type, which is this, and also the oral tube type, which is not commonly used. So external type is by far the most commonest type. So this is actually placed on the side of the neck or at the chin of the patient. So upon placing the device over at the neck or the chin of the patient, it produces a vibration which induces the vibration of the oropharyngeal mucosa at a constant fundamental frequency, which is then channeled to the muscles of the articulation, the tongue, the lips, and which moves and produces the speech. The resulting is actually a monotonous and robotic voice. The upside of using an electrolarynx is that it is very easy to use. It has a short learning time and an easy learning curve. There's no additional surgery required, and there's no any prosthesis insertion needed. The downside is that the voice produced is rather monotonous and robotic. There might be some difficulty while speaking over the phone. Batteries can be costly. It ranges from about 300 to 600 ringgit. And the Electrolarynx device itself, there is quite a range from about 2,000 ringgit to about 6,000 ringgit, depending on the company that you purchase it from. And although it's a small portable device, nevertheless, the patient needs to bring it along everywhere he or she goes to. There are some factors affecting the success of the use of electrolarynx. So based on the study done, they broadly categorize these factors into three major factors, which are patients having a higher social support, patients tolerating a full organ diet 6 months post-operatively, and previous treatment of radiotherapy. So previous treatment of radiotherapy, based on certain studies, have shown that it reduces the success rate of using an electrolarynx to about 34%. And related to radiation-induced fibrosis, it could be a factor why this may affect the treatment of the success of electrolarynx. Now let's move on to the tracheoesophageal prosthesis, also known as TEP. So tracheoesophageal prosthesis is inserted via a procedure called the tracheoesophageal puncture. So it can be done in a primary TEP or a secondary TEP. So primary TEP is usually performed in the same setting of the total laryngectomy, whereas a secondary TEP is done about 6 weeks after surgery or after completion of post-operative radiotherapy. So TEP by definition, basically it's a device which diverts the exhaled air from the trachea into the esophagus, and the air moves upwards towards the pharyngoesophageal segment, and it causes the vibration of the pharyngoesophageal segment. Subsequent articulation of the tongue and lips produces the voice. So this device consists of a one-way valve which allows air to enter from the trachea to the esophagus, but it prevents the fluid and food particles to escape into the airways, causing an aspiration. So the tracheostoma, when the patient is speaking after inhalation, is occluded with the patient's tongue, and then it channels during exhalation and speaking. It channels the air through the valve. So speaking valve is also another option that can be used for patients who prefer a hands-free method of speaking. So it's like instead of using your thumb to cover the tracheostoma, you can put in a speaking valve there, which allows air to enter in. And during normal inhalation and exhalation, there's a valve which allows air to enter into the lungs and exhale throughout. But during phonation, speaking, the pressure of the air will be diverted through the prosthesis when the valve closes. The speaking valve closes its valve, and the air will then be shunted through the prosthesis into the pharyngoesophageal segment. So these are basically the types that we have: the non-indwelling type, indwelling style, and also the indwelling style. So different sizes, different types, but they more or less look quite the same. So the differences between the non-indwelling and the indwelling type. So the non-indwelling type is basically patient inserted. So the initial insertion is of course done by the surgeon, but the subsequent changing, the patient can do it by his or herself. And the thing about it is that it needs daily maintenance and cleaning, and the patient needs to be able to have the ability to have manual dexterity, because the patient would typically look at him or herself in front of the mirror during the changing process. So yes, they need some form of basic cognitive function, and so dexterity. Examples in the examples of the companies which deals with this Bromsinger duckbill type, whereas the indwelling type is clinician inserted. And so during the change of this tracheoesophageal voice prosthesis, the patient will have to schedule an appointment to see the ENT surgeon, and they would have to surgically insert it in the operating theatre. The good thing about the indwelling type is that the maintenance involved is lesser, whereby the patient can use a brush, which comes with the set that they have purchased, to clean it on a regular basis rather than taking it out and putting it back in. And therefore, the manual dexterity is not really needed. And types of indwelling voice prosthesis includes the Bromsinger indwelling type, Provox 2, just to name a few. So this is a short video which demonstrate how we do the primary puncture and the prosthesis placement during the primary TEP. Yeah, just have a go at it. So basically, on the operating table during the total laryngectomy table, after removing the larynx, there is a created tracheostoma over here. So we have to put in the pharyngeal protector, which comes with a set to the pharynx, the pharyngeal mucosa, before we construct the pharynx. And then we feel the tip of the pharyngeal protector at the tracheostoma. So we puncture using a trocar to the pharyngeal protector and insert a guide wire slowly. So this guide wire will go all the way up to the pharyngeal protector, and it has to make sure that you have some certain amount of length between the opening of the pharyngeal protector and the guide wire. So after inserting the guide wire, we can remove the trocar. And after removing the trocar, then only we remove the pharyngeal protector. This is to prevent the trocar from injuring the pharyngeal mucosa if we pull out the pharyngeal protector earlier. So after removing the trocar and also the pharyngeal protector, we can insert this voice prosthetic device to the guide wire from above. And then we insert the other part to lock it securely, making sure it does not get dislodged. And we slowly advance this device together with using the guide wire to the upper end of the pharyngeal mucosa to enter into the tracheostoma. Okay, so this is how it looks like. So upon pulling it securely, gently, you will come to this point where the phalanges are extruded into the tracheostoma. So and then we rotate it to make sure that the pointy part of the phalange facing downwards, and we cut the other the excess of it. So this is how we insert it in the primary DEP. Okay. So next would be a secondary TEP, just another brief video. So secondary one is done when after the total laryngectomy in a separate setting altogether. So we need to use the devices together with the esophagoscope, a rigid esophagoscope. We don't have a pharyngeal protector for this because we are using the rigid esophagoscope. So insert the rigid esophagoscope through the neopharynx, and we can feel the edge of it just like before at the tracheostoma. Insert the trocar through and the guide wire. Just that's how we do it in primary TEP. Insert it outwards, keeping a certain distance, safe distance. Then we remove the trocar, keeping the guide wire in place, and removing the esophagoscope. Same, basically, it's a warning saying that we remove the trocar before removing the rigid esophagoscope to prevent any mucosal injury. We then insert the device through the upper end of the guide wire, slowly bringing it downwards after securing it like just now. And then we pull the device through. Okay. Fastening it securely over until the flange is exposed at the tracheostoma, knowing that we have secured the device. Okay. And then we rotate the device to point the flange facing downwards. And then we cut the tip of it, securing it firmly in place. So basically, this is a brief way of how we perform this procedure. Okay. Let's move on to the next. So the pros and cons of TEP. So the good thing about TEP is that it has a relatively high success rate, and speech develops faster than the esophageal speech, because esophageal speech takes time and the success rate is relatively low as compared to a TEP. So patients are able to start the voice rehab as soon as this procedure is done early on. The patient can also achieve more words with one breath as compared to the esophageal speech. The intensity of the speech is better, and it resembles laryngeal speech. There will be natural sounding speech as well and intelligible speech. The downside of a TEP is that patients, especially the ones who are not using the hands-free type, needs to manually cover the stoma, and it needs regular maintenance. And a good pulmonary reserve it's a must for this. Additional surgical procedure is needed. For example, in a primary TEP, you need to do a tracheoesophageal puncture, and for a secondary TEP, you need to do this surgery in another setting. There is a risk of complications, which are mainly the prosthetic leaks. That means there is a leaking through the prosthetic itself, or a periprosthetic leak, whereby the surrounding region of the prosthesis is leaking. So you have patients can have aspiration from there. There can also be formation of a granulation tissue because of the presence of a foreign body, and block of the prosthesis, dislodgement of prosthesis. It is also quite pricey. and patients will need to have an intact cognitive function and be somewhat independent when using this TEP. Okay, so primary versus secondary TEP. So the pros of a primary TEP is that it can be done in the same setting as a total laryngectomy, so you don't need a separate surgical setting for it. Additional steps, yes, but not a separate surgical setting. There's no delay in voice rehabilitation, as patients will be able to speak early on after insertion of the primary TEP. Appropriate sizing and placement of prosthesis can also be done in the same setting of surgery. And the downside of it is that it requires an additional steps in a total laryngectomy, and there's a risk of periprosthetic leak post-operatively. So usually patients who underwent total laryngectomy, they have to go through a post-operative radiotherapy. So after post-operative radiotherapy, due to the effects of radiotherapy, the muscles can, the mucosa can undergo fibrosis, which then results in maybe sort of a periprosthetic leak around the prosthesis due to the contraction of the mucosa. So that's one of the downside of doing a primary TEP. Whereas the secondary TEP is mainly considered in patients who are not a good candidate for primary TEP. In patients who has complex reconstructions or heavy prior radiation, it also allows for a surgical site to completely heal before the TEP. The downside of it is that it requires an additional surgical procedure in a separate setting after a total laryngectomy. So the success rates of both primary and secondary TB are variable on a case-to-case basis, although studies have actually shown no significant differences in both in terms of success rate. Okay. And in conclusion, basically in selecting how to say perfect voice rehab for our patients, we have to consider multiple factors. Broadly, we can look at it as a patient factor, disease factor, and also surgeon factor. And surgeon factor includes, the ability of the patient to come for subsequent follow-ups, and is that center that we're practicing in capable of extending this form of services in changing and maintenance of, or and also attending to complications related to this TEP. So all these taken into consideration is important for us in deciding what's best for our patient, together with the help of our speech and language therapists, of course. So I think that will be all for me, and these are my references, and I think, proceed with the Q&A if there's any questions, Mr. Moderator. Thank you.
On it. Right. Thank you, Dr. Redzwan Shah, for the detail and brief explanation about the type of the voice rehabilitation post-total laryngectomy. All right. Dr. Redzwan.
Yep.
How are you going to advise patient on choosing type of the voice rehabilitation?
Okay. So basically, my advice would be first and foremost assessing the patient's age, the patient's cognitive function, patient's general condition. So based on that, I can see what methods would be the best for the patient. For example, if the patient who doesn't have any poor social support, who is also doesn't have an adequate cognitive function. So esophageal speech would not be the kind of voice rehab I would advocate for the patient. So I would actually sort of advise the patient towards something much more simpler, such as an electrolarynx, because all the patient needs to do is just to put it up on the chin, so or the underside of the neck. So looking at all that, as I mentioned earlier, I would consider all these factors before prescribing or advising for any certain type of voice rehab for our patient.
Question from Dr. Nofalina. What is the best modality for patient going through radiotherapy?
Okay, thank you for the question. So for patients undergoing radiotherapy, the best modality that I would suggest would be an electrolarynx. Okay, and because it's easy to use, patient can start their voice rehab quickly. So after surgery, while waiting for their radiotherapy, they can actually use the electrolarynx to communicate. They can start off their voice rehab rather than doing another invasive surgical procedure such as TEP. That would be my personal suggestion for the patient.
Right, Dr. Redzwan, is there any society for reference for the patient so that patient can have an example for those patients who underwent total laryngectomy surgery and a reference for them to choose the type of the voice rehabilitation later on?
Yes, there are support groups such as the Malaysian Laryngectomy Society. So this society consists of people who are patients who have undergone total laryngectomy or laryngectomies, which can actually share their journey of in voice rehabilitation among many other types of rehabilitation, and can sort of support newcomers who are entering the society to better guide them and to give them moral and emotional support, and also even aid in their help in learning the esophageal speech. So yes, there is a good support in society for laryngectomies.
Okay, thank you, Dr. Rizwan Shah. Is there any question from the? If no more question, I think that's all the presentation from our department, ENT department. Thank you so much.
Thank you very much.